So, first point is investing in health and then universal coverage is not only an ethical commitment, which is good in itself, but it's actually fundamental to economic and social development. Good health outcomes, if you think about it, lead to higher labor productivity, higher life expectancy and living standard, social and political stability, a challenge which drives health reform in many countries. Financial protection, on the absence thereof, is really the absence of financial risks, is protecting individuals from health shocks, which again is a fundamental economic driver. Responsiveness to patients' expectations, meeting people's expectations, and ensures the support from society for the health system. And finally, a point often underestimated but fundamental in importance is the role of a functioning health system for ensuring a country's competitiveness, both in terms of the cost position of industry through the social contributions, but also by enabling a more productive workforce. There are a number of challenges with universal health coverage, and I would say there are four. The first one is health is driven by the healthcare system, but even more so by social determinants. The second one is, and that has been covered a bit, financing. Where do we find the money for universal coverage? Third one, money is good to have, but money doesn't necessarily buy a functioning workforce and infrastructure. And often insurance reforms are too short-sighted in order to actually ultimately achieve what is required, better workforce and infrastructure. And finally, even if the first three are all in place, in many countries, aging and NCDs combined destabilize lots of healthcare systems and push the fiscal pressure a lot. Now, while this is all kind of really pretty much an agreed set of challenges, the point I'd like to make is that there's actually a lot of progress in these four areas. So in summary, while there are four big challenges, there's, I think, lots of hope and lots of opportunity from leveraging non-healthcare actors, from looking at the innovative financing options, although some of them are quite tough choices, for example, the broad versus narrow, from innovating the delivery model, and from introducing population health, all of which together can create not only universal coverage, but also a better health system. Thank you very much.
The World Health defines universal health coverage as all people receiving quality health services that meet their needs without being exposed to financial hardship in paying for the services. The focus on the universal health coverage debate appears to have shifted from how services are to be provided to how services are to be financed. This discussion is about the sustainability of financing the health systems. What is less discussed is what care is being financed, to whom, by whom, and at what quality. But as any manager knows, in developing a budget in any context, the first step is to work out what you want the budget to cover, and how you finance it is the second step. In recent years, donor funding has moved away from strengthening health systems to targeting specific diseases or health issues such as HIV, malaria, TB, maternal mortality and morbidity, etc. Countries which rely heavily on donor aid to meet essential services are captured by the priorities of the donor rather than the needs of the community. The vertical programme's approach undermines horizontal health system strengthening and does not contribute to the development of an integrated universal health system providing comprehensive care that is accessible and affordable to all. The failure of public health systems is not that they are provided by government, but they are being subject to chronic neglect and underfunding over many years, much of which has been driven by policies imposed on governments by external agencies. Within the universal health coverage debate, all players need to be very careful that governments have flexibility without coercion or pressure, and with support to develop the health systems that suit their current situation and population. The Commonwealth Health Professions Alliance wants to see care as much as coverage as an integral part of the debate on the financing of health and the strong role being promoted for the public provision of health care. Thank you very much. Thank you.
Investing in health in 1993 was a major event in the World Bank, because the first time that the World Bank had dedicated a lot of economic resources to looking at health. And I said they made the point that health is important for two reasons: because health is constitutive, it is a good in of itself, it is good to be healthy. And secondly, because health is instrumental. Health is instrumental to economic growth. And one of the theses they put forward, that it was possible within health to have what they call a grand convergence. That if you looked at some countries that were not doing well and countries that were doing well, it is possible to design systems that led to a grand convergence, that the two systems, the two things could converge. Much of what they recommended in terms of convergence was to set as an example countries that had done well. A former director of Park used to say, if you want a country to do well, you have to start with a C. The Chile, Costa Rica, the Caribbean, you have to have a country to do well. Cuba, you have to have a country to start with C. But never mind, they use these countries as benchmarks and pointed out that if you introduce the right principles, the right practices, and the right procedures, you could have countries converge. Initially, they thought of convergence only in terms of certain problems mainly affecting mothers and children, the maternal child health problems, and they costed what it would take to achieve this convergence within 20 years. But they set out, that was not the only message that this commission set out. They set out essentially four messages. One, as I said, there still is evidence that there's tremendous benefit to be got from improvement in health. Two, this grand convergence in health is achievable within our lifetime. It's not something for nirvana, it's something within our lifetime. And the third was that we have in our instrument case fiscal policies that are powerful and underused for curbing the non-communicable diseases and injuries. And what, however, is of more relevance to this afternoon's discussion is the fourth, that there are progressive pathways to universal health coverage and an efficient way to achieve health and financial protection. You cannot have good health care without good health coverage. So I would defend the thesis that it is not really very helpful to separate the two. You cannot have good health care without good health coverage. Now, in conclusion, the Minister of Health from Jamaica said, let us remember, universal coverage is a journey, not a destination. You don't achieve universal coverage and say, I have universal coverage perfectly. It is a journey. And all of us start on this journey. I mean, all of us, I don't run a country. All of the countries start on different stages and will progress according to their own capabilities. Just remember that. Most countries will fall short on one or other of the three dimensions. Most countries will fall, some will fall short in terms of population coverage. Some will fall short in terms of cost per paid, and some will fall short in terms of intervention covered by prepaid schemes. That is the nature of the beast, but that should not discourage them from proceeding along all three dimensions. The other one is resources are limited. Aspirations are inexhaustible, and resources are finite and limited. And health policy and politics, let me make the difference. My minister knows the difference very well between policy and politics. Health policy and politics will often determine if movement proceeds. in a balanced way of privileges, one or the other.
So we think in a universal health coverage or universal health care, sustainability is an important element, and healthcare products. It includes pharmaceuticals, that's medicines, vaccines, diagnostics, and other medical devices. These products should be available at an affordable price. Then only the system can sustain it. If it is not available at an affordable price, you cannot provide UHC. So determinants of access to medicine. One of the important determinants is sustainable finance. And who can make a sustainable financing mechanism for medicine is primarily by a public financing mechanism. And you need a public procurement and distribution of medicine. And in order to make it a sustainable public procurement and distribution system, the medicine should be available at an affordable price. One of the important factors which determine the availability of medicine at an affordable price is through local production. This local production need not be at the national level. If there are regions where you cannot achieve the economy of scale, then there should be regional hubs for production, at least for the essential medicines. And one of the important elements which is going to determine the local production is the patent law and intellectual property law. I'll come to that. Then rational use of medicine. This is very important component because we are facing a major drug resistance when it comes to antimicrobials. And this World Health Assembly is going to deliberate and hopefully going to adopt a global action plan on antimicrobials. And this is, many countries have flagged this as one of the biggest threat to health security.
You can always look at any country's health system and point out gaps. UHC is about a progressive movement towards this ultimate objective, which is never really attainable. It's sort of some nirvana out there in the future. And UHC is more about the progress, about the story of how we get there. The countries who've achieved UHC rely on taxation and sometimes also on social health insurance to achieve it, but in combination. These are the only two proven ways or two primary financing mechanisms that countries have used to be able to get there. Starting with social health insurance, because that's actually the oldest version, the older of the two, dated from the 1860s. The unfortunate reality is that social health insurance in the classic sense, or even in its modified sense, has only been successful in achieving UHC in a handful of upper middle income, high income economies. Traditional social health insurance, which is contributory, was never able, even in rich countries, to cover the poor and those outside the formal sector. So for those countries, developing countries who think they can use traditional social health insurance to achieve universal coverage, they should realize that even rich countries like Japan and Korea were not able to do this. What's happened in the 20th century after Bismarck died was that countries modified social health insurance to create what I call a national health insurance model. And in the national health insurance model, what happened was the countries decided to use government tax money to extend insurance coverage to the poor or those outside the formal sector. And these are what I call a mixed NHS and private system. And in this system, there are economic and political constraints which prevent governments spending enough money for a fully funded NHS. But what they do is they allow two systems in parallel. They make sure the public sector is fully accessible, provides decent quality services, and that the poor can actually use it. And they encourage the wealthy or the non-poor to voluntarily migrate to the private sector, usually for reasons of better consumer quality, not because they actually get better medical care. To do that, you have to target your public delivery system to the poor. Now, this is what actually happens in most countries. Public sector is targeted to the rich. This is the case from Indonesia, just as effectively as private services are. So in Indonesia, the public sector does as badly or as well as the private sector in reaching the poor. But in these mixed systems, and Sri Lanka is an example of this, it's the opposite. In mixed systems, the private sector still targets the rich, but the public sector is able to target the poor effectively. if one looks at these mixed systems are doing as well as those better-known UHC stars, but they're doing so with much less public spending. So these are the countries ranked in terms of public spending as a share of GDP, and the yellow ones are these mixed systems. The other ones are the well-known UHC stars. These countries achieve the same health system outcomes as those better-known countries, but do so by spending less public money. And they do so using that mixed model. So just to finish, high income status is not a necessary condition to achieve UHCs. The evidence indicates developing countries can achieve it too. Secondly, you need tax money to do this, whatever you do. Third, I would argue that the standard models of an NHS or social health insurance may not be feasible in most developing countries. But importantly, and I think for this meeting in particular, there is a mixed public-private model which has been able to do this in many Commonwealth countries, which is not talked about a great deal, but it appears to be effective in achieving those outcomes with limited tax resources. Thank you.
The needs of education. I think that the conclusions reached today are very similar to what we're experiencing in most countries.
No country starts in a vacuum. All countries start somewhere.
I think in terms of progressivity, that's a very important concept. I think it's very important that the reality is countries have to move over time to improve what they have. And I think that's a very important concept. This is not a question of yes or no. But at the same time, one of the points I did make earlier was that even though that's true, I think you can say that countries, even in that journey, there are countries who have largely put things in place which are appropriate for that step in the journey. And that we can ask for, even if they can't go to the nirvana today.
Okay. So whether we need further clarity on that. When we talk about insurance systems or the actors in the UHC, so what's the role of private sector and how do you regulate them? And also the question is that the third world governments, do they have the political capital or even the negotiating capital to control the big corporations?
Although everybody on the panel agrees that tax is a fundamental point in that, or in whatever form forced contributions. We didn't get to two quite important questions. One is the big challenges which are increasing and accelerating technological innovation and more complicated. We talked about AMR market failure, we talked about biosimilars, where it's not so clear what actually the patent could be on. And there's a big debate. We didn't talk even about genomic and other developments which are around the corner, which means there is enough space for yet another intelligent debate. So with that, I would like to thank everybody for their contributions and wish you a wonderful evening.
Thank you very much.
Thank you very much.
Thank you very much. Thank you very much.